Hello guys, welcome to our channel. Today we'll be discussing the part 2 of the Sureshot series. In the part 2 we'll be discussing another 50 plus topics guys, and the last part 3 will be discussed tomorrow and another 50 plus topics. So we will be completing the 150 plus topics in these 3 parts, and very highly recommended for you guys to watch this before the examination, and at least we can expect 50 to 80 concepts in the final examination. Those who are new to this channel, please do subscribe to the channel and share with your friends, and also do watch all the 19 subjects rapid revision videos, and also do watch this Sureshot series, and I'm telling you that this is definitely going to help you out in the examination. So let's start the discussion guys. So first we will be discussing of the anatomical triangles. So here you can see this is the triangle of the cubital fossa, right? This is a triangle of cubital fossa. And what are the contents of the cubital fossa? That is most important. Rather than the borders, you can easily identify the borders. So this is the lateral border, brachioradialis, and the medial border is the pronator teres. Okay, and upper border, which is known as a epicondylar line, that is a superior border. And whatever the content guys, content is should be remembered with the mnemonic of the MBBS. Okay, from the medial side to the lateral side, so it will be on this direction. So MBBS, that is the median nerve, brachial artery. This is the brachial artery. And next here it is biceps. Here you can see this is the biceps tendon. And next last one is the superficial radial nerve. This is the superficial radial nerve. Okay, so these are the contents that is present inside the cubital fossa. Most important one is the brachial artery for the pulsation. Next, coming to the next one, this is the femoral triangle, right? This is the femoral triangle. What are the borders of the femoral triangle? The first border, that is the superior border, is the inguinal ligament. And coming to the medial side, the medial side is the adductor longus muscle, and on the lateral side you have the sartorius muscle. Okay, the lateral side will be the sartorius muscle. And whatever the content, so the content that is present here is the femoral vessels. Okay, femoral vessels, both the artery and the vein. And along with that you also have the femoral nerve. Femoral nerve is also present here. And next, the another one is the genitofemoral nerve. So this is also a femoral branch. Genitofemoral, we have two types. Okay, one is the genitofemoral genital branch, one is the genitofemoral femoral branch. Okay, these are the contents of the femoral triangle. Next, popliteal fossa. This is the popliteal fossa. And in the popliteal fossa the borders are four. So the first, above both the superior borders, which is semi membranous, and also biceps femoris, semi membranous, and the biceps femoris on the superior side. On the downward, they are medial head of the gastrocnemius, lateral head of the gastrocnemius. So these are the borders of the popliteal fossa. Coming to the popliteal content, what is the popliteal content guys? Here you can see the content will be the common fibular nerve, that is a common fibular nerve, popliteal artery, and the popliteal vein. And also here you can see this is the sciatic nerve and tibial nerve. So what are the three nerves that is present here? One is the tibial nerve, other one is the common fibular nerve, popliteal artery, and also sciatic nerve. Okay, these three nerves which will be present inside the popliteal fossa. Next, this image based question that has been asked, right? So this is on your thumb side, right? This is on your ulnar side. So what are the muscles that is passing? What is the muscle tendons that is passing here? So this thick one, this is known as a palmaris longus tendon. This is the palmaris longus tendons. Next, this one is known as a flexor carpi radialis. Flexor carpi radialis. Next, just beside this one, sometimes it is not even visible, and this one is known as a flexor carpi ulnaris. This is the flexor carpi ulnaris. So this is the ulnar side, this is the radial side. So flexor carpi radialis, flexor carpi ulnaris. In between one, that is the thick one, that is known as a palmaris longus. Next, coming to the anatomical snuff box. Anatomical snuff box, the important parts that you have to remember is the what are the tendons that is forming here. So this is the downward and this is the superior. So on the superior, this is the tendon of the extensor pollicis longus. This is the on the superior side. Okay, and in the inferior side you have the tendon of ipsi, the extensor pollicis brevis, and also adductor pollicis longus. These both are present here. Next, and what is the content that is present here? Content is mostly radial artery and radial nerve. These are the two contents that is passing here. If ever there is a fracture of the scaphoid, If ever there is a fracture of the scaphoid, the patient will be feeling the pain in the anatomical snuff box, right? Next, another triangle. This is the Hasselbeck triangle. This is the Hasselbeck triangle. In the Hasselbeck triangle, what are the borders again? So the border is on the medial side is the rectus abdominis muscle, okay, and on the lateral side, this is the inferior epigastric muscle. This is the inferior epigastric muscle on the lateral side. And coming to the inferior side, this is the inferior side, okay. The inferior side, which is known as a inguinal ligament. This is the inguinal ligament. This is going to form the border, right? This is the one which is going to form the border. But the important part, why it is important for the Hasselbeck triangle, it is going to differentiate between the direct hernia and the indirect hernia. So the passage of the hernia sac, that is a direct hernia in the Hasselbeck triangle. Next, hepatocystic triangle and the Calot's triangle. So this is the Calot's triangle, right? So on the upper part you have the cystic artery. Upper part you have the cystic artery, and on the superior part is the cystic artery, and next in the medially you have the common hepatic duct, and on the lateral side you have the cystic duct. So, okay, so this is the lateral, medial and the superior. Next, hepatocystic triangle. On the superior, what you have? Superior you have the liver border, right? Superiorly you have the liver border. Next, on the medially, common hepatic duct. On the laterally, cystic duct. So the important point here is the cystic artery. How the cystic artery is uh, forming the border. For example, see here. So Calot's triangle is so important. We may injure during the laparoscopy of the cystectomy, right? Cholecystectomy. So that's why we have to make sure that we are not dissecting into the cystic artery, rather than we pushing more on the upper side of the triangle, right? Next, moving on to the pulsations. Important pulsations that you have to know. On the cubital fossa, as I said, that is a radial artery, and nearby the anatomical snuff box, this is the radial artery. Next, in the popliteal fossa, popliteal artery, and on the anterior side of the legs, that is the dorsalis pedis. On the medial side, it is a posterior tibial artery. Okay, this question is asked. And next, in the inguinal region, it is a femoral artery. On the superior, on our forehead, it is the temporal artery, and nearby the chin it is the facial artery, and then in the neck it is the carotid artery. Image based questions can be expected here. Next, pharyngeal arteries and the pharyngeal derivatives. So pharyngeal derivatives is most important, guys. So we all know that the pharyngeal arches is going to give rise artery and the nerve, and also some of the organs. Let's see one by one. So first arch which will be gives rise to the mandibular artery. So this is going to give rise to mandibular artery, and also maxillary nerve, and malleus incus. Okay, malleus and incus also is coming from the first arch. Next, second arch. Second arch is going to give rise to the stapedial artery and also stapes. Okay, styloid processes. Next, the second arch is also going to give us is the facial nerve. Facial nerve. Next, third one is going to give rise to the glossopharyngeal nerve and the carotid arteries. Okay, carotid arteries, which is also coming from here. Next, this is the fourth arch. In the fourth arch, it is going to give us arch of aorta and also laryngeal nerve. Okay, laryngeal nerve. This laryngeal nerve is a superficial laryngeal nerve. Next, this is the sixth one, right? Fifth one will be degenerative. Next, sorry, this is the sixth one. The sixth arch is going to give rise to the recurrent laryngeal nerve. It is going to give rise to the recurrent laryngeal nerve, and right and left pulmonary artery. Right and left pulmonary artery. And in the during the fetus development, it is also going to give us ductus arteriosus. Also going to develop the ductus arteriosus. These are the derivatives of the pharyngeal arches. Let's see here the images. So the derivatives, that first derivatives are is this one, masseter muscle as also belonging here, anterior belly. Sorry guys. So this is the first and second, which first one This is the both are in the first arch derivatives. Okay. Next, these are the second arch. Occipital, auricularis. These are the second arch, and also posterior belly of the digastric. Next, stylopharyngeus is belongs to the third arch. Stylopharyngeus is belongs to the third arch, and the fourth arch is a pharyngeal muscles. Fourth arch is a pharyngeal muscle, and also temporalis is the first arch. These muscles also in the first and second arch derivatives. Next, see here, malleus and incus is the first arch, okay, and the stapes is the second arch. Styloid process, second arch. Stylohyoid ligament, great great corner of the hyoid bone is from the third arch. Okay, thyroid cartilage and the circoid cartilage is by the fourth arch. Okay, it is by the fourth arch. And coming to the lesser hyoid bone, this is also from the second arch. Meckel's cartilage, this question has been asked. This is also from the first arch. Okay, these are the derivatives that has been asked previously. Next, JVP. So in the JVP, what is normal JVP? JVP, we are just looking at the right atrium function. Okay, right atrium function. So at the angle of the 45 degrees with the help of the scale, from the scale at the internal jugular vein to the sternum you have to measure. Okay, to the sternum you have to measure, and it will be around 4.5 centimeters gap. The 4.5 centimeters gap will be present, and when you are measuring this, you are going to see these waves. What is the A wave signifies? It is a atrial contraction because there will be elevation. Next, atria, once it is relaxed, it is going to show the descent. Okay, it is going to show the descent, that is known as a first X naught descent. And next, C wave. C wave is tricuspid valve closure, tricuspid valve closure, and tricuspid valve bulging. Why the tricuspid valve bulging here? Because of the ventricular contraction here happening, and after the ventricular contraction, whole muscle is going to relax, right? So this is going to be the isovolumetric relaxation. First X systole we are going to see here. Next, after that, there is a V wave, and the V wave signifies the maximum atrial filling. So V wave is maximum atrial filling is going to show, and after that there is a tricuspid valve opening, and that is the wide descent, and the atria is going to empty. These are the important waves that is going to present it, right? Next, what are the conditions that is associated with this JVP defects? So there is an absence of the A wave. It is possible that A wave can be blunt, right? A wave is blunt, or if there is an absent of the descent, for example, Y descent is absent. Y descent can be absent. Why these two waves are absent? Because this is seen in the atrial fibrillation. So obviously P wave is absent in this patient, so as the A wave is also absent. And absent Y wave, it is seen in the cardiac tamponade. This is seen in the cardiac tamponade. Okay, next belongs to the fourth one, that is the X descent. X descent is prominent. X descent prominent is seen in the patients of the constructive pericarditis. Constructive pericarditis. Next, Canon A waves. Canon A waves. C for Canon A waves. C for complete heart block. This is seen in the complete heart block. Right. Next, giant A waves. Giant A waves. Giant A waves is seen in the tricuspid stenosis. Tricuspid stenosis, and also A wave plus V wave is merged. This is known as a Lancisi wave, seen in the tricuspid regurgitation. A wave and V wave is merging together, that is seen in the Lancisi wave. Okay, these are the important points that you have to remember, guys. Sorry, A wave and C wave, that is a Lancisi waves. Next, hypothalamus areas. So hypothalamus nuclei is going to give rise to the multiple important points, right? Just remember this, hypothalamus is having the two sides. One is the anterior side, nuclei, and also posterior side, nuclei. And we all know that hypothalamus is important for the maintenance of the temperature. Okay, importance of the maintenance of the temperature. And anterior side is for the heat temperature, and posterior side is for the cold temperature. Okay, next, suprachiasmatic. So suprachiasmatic is the circadian rhythm. This is a circadian rhythm. And next, supraoptic is ADH. Okay, supraoptic is the ADH. And next, paraventricular This is for the oxytocin and mammillary bodies. Okay, this mammillary bodies is for the memory, and ventrolateral nuclei, this is for the sleep, important for the orexin. Okay, ventromedial is for the satiety. Okay, ventromedial is sleep, and the ventromedial is for the satiety. Okay, these are the important hypothalamus areas, right? Next, oncogenes. RAS-K is for the colon cancer and the pancreatic cancer. RAS-H is for the renal cancer and the pituitary carcinoma. RAS-N is for the melanoma. ABL is for the CML. BRAF gene is for the hairy cell leukemia. MYC-C is for the Burkitt's lymphoma. MYC-N is for the neuroblastoma. MYC-L is for the lung carcinoma. And cyclin D is for the mantle zone. PDGF is for the astrocytoma. FGF is for the fibrosarcoma, osteosarcoma. HGF is for the hepatocellular carcinoma. PDGFR is for the glioma. EGFR1 is the adenocarcinoma of the lungs. EGFR2 is for the breast cancer. Red gene is for the MEN syndromes 2A and the 2B. And the KIT is for the GIST, AML, melanoma, and seminoma. ALK is for the adenocarcinoma of the lungs. CDK4 is for the glioblastoma. Next, tumor suppressor genes. P53 is the 17p chromosome location. Lee-Fraumeni syndrome. Multiple types of the cancers will be seen. RB gene is for the 13q retinoblastoma plus osteosarcoma plus pineloblastoma. These are known as a triblastic tumors. Next, NF1 neurofibromatous 1 is the 17q neuroblastoma. NF2 22q on the schwannoma. BRCA1 is for the breast cancer. BRCA2 is for the male breast cancer. Okay, male breast cancer. And also BRCA1 is for the ovarian cancer. And WT1, WT2, that is for the Wilms tumor. VHL is for the renal cell carcinoma. That is a Whipple-Hindoo syndrome. Next, tumor markers. Calcitonin is for the medullary carcinoma. AFP is for the yolk sac tumor and the hepatocellular carcinoma. Beta HCG is for the germ cell tumor. And the prostate cancer is the prostate cancer. PSA is positive. And catecholamines is for the pheochromocytoma. CEA is for the colon cancer. CA72 stomach cancer. CA19 is the pancreatic cancer, best option. And CA15 is the breast cancer. CA125 is the ovarian cancer. Okay, these are the tumor markers. Next, urethral trauma. Urethral trauma is two types. One is a bulbar trauma and other one is a membranous trauma. So where the bulbar trauma is happening, for example, here you can see if there is a damage here exactly at this point, at the before the bifurcation of the membranous urethra, if there is a damage in the bulbar urethra, this is most of the anterior type. So what happens in the patients? So here itself you can see the image, there is a break here. So what happens? The urine is going to extravaginate here. Urine is going to come here. Urine is going to come here. But urine cannot travel to upsides, right? So the urine which will be exaggerating around these areas, for example, superficial peroneal pouch, scrotum, and Buck's fascia, and also leaks into the penile region and the anterior abdominal wall. This is the most anterior type of the urethral injury. Next, see here, this is the membranous urethra at this location. Membranous urethra, it is cannot come here, right? But it will exaggerate here only. So this is present in the deep peroneal pouch and also retropubic space and also around the prostate and the bladder, but it is not on the anterior abdominal one, on the scrotum. So main distinguishing feature is the scrotum filling. Scrotum filling is seen in the anterior one. Scrotum is not filled around only at the location of the only a rotation of the prostate, then it is known as a distal, or then it is known as a more proximal membranous urethra and the posterior urethral injury. Next, chest trauma. So here you can see these are the images that you have to might be also have to see, identify them. First, let's see what is this picture, guys. This is the pneumothorax. The picture here you can see is the pneumothorax. Obviously most common cause will be trauma, right? Simple pneumothorax is very rare, but the most common cause is the tension trauma, right? So these pneumothorax patients, how the patients will be presented? First, so patient will be having increased ventilation, so the heart rate will be increased and cardiac output is decreased. Increased JVP, you are going to see increased JVP also, and patient might be having the shock also. So obviously decreased heart rate and decreased BP is also present in this patient. This is the vitals. And what happening here? So the heart, the lung is going to shrinking back, right? The lung is shrinking and all this is filled with the air. All is filled with the air and also compresses the cardiac activity, right? Cardiac activity is also decreased in this patient. On the X-ray, As you see here, X-ray, you are going to see the lung collapse, right? Lung collapse is seen, and also lack of the lung markings will be decreased, and also plus barcode sign is seen on the ultrasound, barcode sign is seen on the ultrasound, and trachea shift is also seen. Okay, trachea shift is seen towards the opposite side, right? Next, how you are going to treat this patient? So treatment for this patient is, generally we have to go to do the immediately needle compression. Needle compression has to be done, followed by you have to do the tube insertion. Okay, tube insertion has to be done. So where is the location for the adult patient? It is the mid axillary line. This is the, sorry, mid clavicular line. Mid clavicular line, you are going to put at the location of the fifth intercostal space. Fifth intercostal space. Next, children. Children is mid clavicular line on second intercostal space. Second intercostal space. This is where we are going to do the needle compression. Next, coming to this picture, this is the hemothorax. Okay, this is the hemothorax. So the patient is having the hemothorax is going to show this U shape of the thorax, and the patient is going to have on the percussion same symptoms, but percussion note will be dull because of fluid exaggeration here. And treatment here is a chest tube insertion for this patient. Chest tube insertion should be done. Next picture, here you can see this is a failed chest. So failed chest. So failed chest is nothing but, here you can see these are the rib fractures. Multiple rib fractures is seen. Okay, at least more than equal to 2 types of the rib fracture, plus or minus patient will be having paradoxical breathing. Paradoxical breathe. Okay, plus or minus pneumothorax can be developed patient, or the hemothorax is seen, and plus or minus there will be contusions of the chest and lungs. So this patient has to be treated with the immediate O2 therapy. Supplementation has to be given. O2 therapy has to be given for this patient, and adequate IPPV is, if it needed, you can also give that one also, analgesia. Okay, and if the patient is not presented with the pneumothorax, what you have to do? You have to maintain the saturation and also prevent the pneumothorax formation. That has to be done in the failed chest. Okay, next, coming to the cardiac tamponade. This is the cardiac tamponade. So this is the cardiac tamponade, but your heart is at this location only. All this is fluid. So this fluid is compressing the heart, right? This is present in the pericardium. This is the heart, right? This pericardium fluid is pushing and pushing, and it is going to cause, and this is most commonly due to trauma. Okay, cardiac tamponade. Cardiac tamponade is having the criteria, right? That criteria is known as a Beck's triad. Beck's triad tell us decreased BP, hypotension, and muffled heart sounds. The heart sounds is not that much prominently heard, and increased JVP, increased JVP, plus Y descent is absent. Y descent is absent in this patient. Obviously, the patient cardiac output is decreased, blood pressure is decreased, and eventually the patient can go into the cardiogenic shock. Cardiogenic shock. Okay, that is the one you are going to see. And what is the treatment for this patient? Pericardiocentesis. So previously this is the pericardiocentesis is done, but nowadays this is the optional procedure. Nowadays it is the pericardiodectomy. Pericardiodectomy is applying for these patients. Next, gout and therapy. So gout have the multiple conditions, right? First, acute gout and the chronic gout. So acute gout versus the chronic gout, uric acid levels are normal, uric acid levels are abnormal in this patient. And the risk factors for this patient is the alcohol, middle age. Okay, alcohol and the middle age is common examples for this patient. And here it is the CKD. The patient might be having the kidney disease, or the patient might be having any other comorbidities. These are the chronic symptoms, and the most common location is the big toe, right? Metatarsal joint. This is the metatarsal joint that is involved here, the most commonly. This one we call this as a podagra, very painful condition. And here the most common location is knee. Most common location is a knee. And for this patient, treatment is NSAIDs. Okay, the drug is indomethacin. Next, followed by, if it is not treated, then you can add the colchicine. You can add the colchicine. Colchicine have the it will prevent the migration of granulocytes so that the inflammation is decreased. So it will inhibit the migration of the granulocytes. And treatment for the chronic, you have to stop the uric acid levels. So allopurinol. Allopurinol mechanism is xanthine oxidase inhibitor. This is the xanthine oxidase inhibitor. This is the acute and chronic. Next, we also have the pseudo gout. Pseudo gout is most commonly due to uric acid is normal, but calcium pyrophosphate levels are increased. Calcium pyrophosphate levels are increased. So that's why it is known as a pseudo gout. And here also most common location is knee. Most common location is knee. And the treatment for this patient is also NSAIDs, whatever the painkillers like naproxen or acetaminophen that you can give for this patient. But the another point that you have to remember is the microscopy. So another point is the microscopy. So patients with the gout condition, patient with a pseudo gout. So what we discussed here, there is an increased calcium pyro levels, and here monosodium urate crystals. This is the monosodium urate crystals, right? So how they are going to look? So monosodium urate crystals, this is going to look as a needle shaped. This is the needle shape with negative birefringence. Negative birefringence that is seen here. And the calcium pyrophosphate look like rhomboid with positive birefringence. Okay, P for pyro, P for positive, and also rhomboid. This is how they are going to look like. The one thing that you have to remember. Next, uric acid. Uric acid increasing drugs. What are the drugs that will increase the uric acid? Example, diuretics and thiazides and loops, right? This will increase. TB drugs will also increase. Niacin will increase. Aspirin will increase, right? Aspirin is also going to increase this one. And also the drugs like methotrexate will increase. Cyclosporine, all this will be increasing the drug induced uric acid levels. Next, uric acid analogs. So these uric acid analogs which will bind to the uric acid and also going to convert them into the low toxic levels, uric acid analogs. So the drug name is also ends with rasburicase, and this is used for the patients of the tumor lysis syndrome. This is used for the patients of the tumor lysis syndrome in the leukemia patient. Okay, next, uricosuric. So through the urine we can send them, via urine you can excrete the uric acid. Okay, and what are these drugs? The drug that commonly present is the probenecid. Okay, probenecid is the drug that is going to have. So these are the uric acid and the gout therapy and some of the uric acid drugs. Next, moving on to the migraine therapy. Okay, moving on to the migraine therapy. Before the migraine therapy, you have to take note of the other conditions also. For the tension headache and for the cluster headache, what is the treatment? For the tension headache, treatment is NSAIDs. Naproxen is the first drug of the choice. Next, cluster headache, the treatment is O2 therapy. Okay, high O2 therapy has to be given for this patient. And for the migraine, if you divide, this is the acute stage, we doesn't know the diagnosis, then we give the NSAIDs. But if it is a chronic and if you diagnose properly, then the drug of the choice is triptans. Okay, drug of the choice is triptans. And how about the pregnancy patient? Pregnancy patient also it is a triptans drug of the choice for this patient. Okay, drug of the choice will be the migraine headache only. Next, sometimes in the these triptans are contraindicated in specific situations. For example, ischemic heart disease, cardiovascular disease, and cerebrovascular accidents. Okay, all these patients we are going to, and also pregnancy patients in the first trimester, especially during the organogenesis, we prefer not give the drug with this triptans. Next, Coming to the prophylaxis is also going to be important. For the tension headache, it is the SSRIs. For the cluster headache, it is the verapamil, okay, or steroids on the prophylaxis. And coming to the migraine, the drug of the choice is beta blockers such as propranolol, or you can also give the topiramate. This is the anti-epileptic drug. Amitriptyline. Amitriptyline can be given. Botulinum toxin is given for this patient, and galactinuzumab. Galactinuzumab, that is also given as a drugs for the prophylaxis of the patients. Okay, prophylaxis of the patient that we can give for this patient. Right. Next, epilepsy and the drug of the choices. Epilepsy and the drug of the choices. So the first and foremost important one, that is a febrile seizure. So immediately whenever the patient is having the febrile seizure, you can go for the benzodiazepines, that is the lorazepam is given for this patient. Okay, lorazepam is given for the patients of the GTCS. First line, okay, first line is the lamotrigine. Okay, lamotrigine. But if they have to ask the GTCS, then you have to choose a valproate as a drug of the choice. Valproate as a drug of the choice. Lennon-Gastaut syndrome, Dravet syndrome, and myoclonic seizures, all absence seizure, all these are the valproate. All the choice will be valproate only. Next, neonatal, especially in the newborns, neonatal. For this patient, they will be having subtle seizures, and these subtle seizures, we can give them phenobarbital. Okay, phenobarbital. And patients with a low glucose, you have to give the dextrose. Okay, status epilepticus, status epilepticus, that means more than 15 minutes continuously. How you are going to treat? First, lorazepam, first line. Then if it is not controlled, then you can go for the phenytoin. Still not controlled, go for the valproate. So that means two medications is already not preventing, then you have to go for the anesthesia techniques. Okay, completely suppress the patient consciousness. That is how we can do. Next, infantile spasms or West syndrome. This is ACTH, and West syndrome with tuberous sclerosis. And here we are going to give the vigabatrin. Vigabatrin is given for this patient. Pregnancy patients. In the pregnancy, for example, the patient is having the history of the epilepsy. Then the patient is on the first drug, but she came after 3 months of the pregnancy. Unfortunately, she came after the 3 months of the pregnancy. So continue the same drug. Whatever the drug, you can continue that one. So, but patient is came with the epilepsy history prior to the pregnancy. So this prior to the pregnancy period, we can start the patient on the levetiracetam. Okay, we can start the patient on the levetiracetam. Okay, levetiracetam has been given for the patient's pregnancy safety. So let's say that the pregnancy patient with no history but presented with the hypertension plus eclampsia. For these seizures, you are going to give the IV plus IM MgSO4. IV plus IM SgSO4, that we are going to give this for this patient. Right. Next, audiology and the charts that is asked. So here you can see this is the Carhart notch. Carhart notch at the 2000 Hz. This is seen in the patients of the otosclerosis. And the other test we do for this patient is the Gellert test with the fork. Tuning forks, we are going to do the Gellert test. Next, audiogram that you can see here. The dip is at the 4000 Hz. The 4000 Hz dip is seen with the noise induced. This is seen in the noise induced hearing loss. Next, here you can see there is a slope, right? Up slope is going. This is seen with the Meniere's disease. Okay, this is seen with the Meniere's disease. And next, this is the downfall is seen. This is the age related, or we also call this as a presbycusis, right? This is a presbycusis. Next, tympanogram. Tympanogram questions has been asked last year only, so should not be forget. Type A is the normal audio tympanogram. Okay. Next, type AS is seen with the otosclerosis. So bony degeneration of the otosclerosis, and type AD is seen with the ossicular dysfunction. Ossicular dysfunction. Type B is seen with the middle ear dysfunction. Type C is seen with the ET dysfunction. ET dysfunction. Here you can see type C, type B, type AD, and also type AS. Okay, these are the things that you have to remember, guys. Next, larynx disorders. Here you can see there are the different types of the larynx disorder rise. So first one, laryngeal ocal nodules. What is the location? Here you can see this is the 1/3 of the anterior. This is the 1/3 of the anterior, and this is the 2/3 of the posterior. Okay, and these are the bilateral, most commonly seen with the singers or teachers. What is the treatment for this patient? Speech therapy, or we can also give the rest. That is for the ocal nodules, right? Next, here you can see this is the ocal polyps. Ocal polyps is unilateral and same location, right? 1/3 of the anterior and 2/3 of the posterior location, right? This is the polyps. For these patients, we have to do the laser surgery. Laser surgery is done for this patient, right? Another one, this is, you can see, this is a laryngomalacia. Laryngomalacia seen in which patients? Laryngomalacia is seen in which patients, guys? This is seen in the children or newborns, and they present with a stridor. Only typical stridor you see in this patient, that is known as a laryngomalacia. And what is the treatment for this patient? Assurance. So eventually, by the time of 2 years, it will be going to regress, and the shape that you are going to see is the omega shape. Okay, omega shape is seen in this patient, right? Next, Rinke's edema. Rinke's edema is seen especially in the smokers. Rinke's edema will include whole true vocal cords and the false vocal cords. It is going to involve. Okay, it is a bilateral and full length. It is involved, right? And the treatment for this patient is the stripling. Stripling has to be done for this patient. Laryngeal keratosis. This is a laryngeal granuloma, and glottis sulcus, where is a dilatation is seen, and intracaudal cyst. These are the different types of the laryngeal disorders. Next, laryngeal carcinoma. Okay, laryngeal carcinoma. Laryngeal carcinoma stages are important. Stage 1, TNM stage 1, only the one cord is involved, one vocal cord is involved. T2, more than one cord plus structure is involved. T3, it is fixed vocal cords, so there is no change in the movement. Next, T4 is the extensive stage. T4, for this patient it will be beyond thyroid cartilage. It will be beyond the thyroid cartilage. Surroundings is involved. So first two patients, we can go the laser surgery and removal of the growth. And for this patient is also removal of the tumor. And here you are going to do the laryngectomy. Laryngectomy plus chemoradiation. Chemoradiation is done for this patient. Okay, this is the important point. Next, nasopharyngeal carcinoma. This is due to Epstein-Barr virus, and location is Rosenmuller. Location is Rosenmuller of fossa. Fossa of Rosenmuller, that is the location. Okay, this question is asked. And for this patient, the common symptom is cervical lymph adenopathy, and the treatment is for this patient is the chemoradiation. Chemoradiation, right? These are the important larynx disorders. Next, larynx nerve supply, right? Larynx nerve supply. So the larynx nerve supply is mainly coming from the vagus nerve. It is coming from the vagus nerve. Okay, Vagus nerve is going to give rise to the laryngeal nerve. This is going to give us a superior laryngeal nerve, and this is going to give us the external laryngeal nerve and then internal laryngeal nerve. Okay, and external laryngeal nerve is supplies the glottis. Okay, it will be supplied by the glottis. Okay, and internal laryngeal nerve, it is going to supply the superior glottis. Okay, sorry, supraglottis is supplied here. And next other one is the recurrent laryngeal nerve, and this is going to supply the glottis plus subglottis. Okay, it is supplied by here. Okay, and external laryngeal nerve is also supplied the circothyroid muscle is also supplied here. Next, you have the two types of the laryngeal disorder. One is bilateral abductor and bilateral adductor. So what is the problem in this both? Bilateral abductor, so there is no abduction. Here there is no adduction. So obviously what is the position? So the position when there is no abduction, so the vocal cords will be in the middle, right? Vocal cords will be in the middle. So obviously the patient with the abducted palsy, there will be having the respiratory distress, and this condition is severe condition. So here you have to do the intubation immediately, and intubation is not possible due to the abduction, then you have to go for the tracheostomy. Tracheostomy is done for this patient. Okay, tracheostomy is done, and after the time you can go for the thyroplasty type 2 lateralization of this patient. Okay, bilateral abductor palsy, right? This is seen. Next, bilateral adductor palsy. Bilateral adductor palsy means the position will be, so there is no adduction, so obviously they will be in the abducted position. So the patient respiration is normal, so there is no distress, but phonia symptoms, the patient is having the phonia symptoms. For example, speech abnormality is seen in this patient, and highly risk for the aspiration risk is seen in this patient. And the treatment is thyroplasty type 1 is medialization is done for this patient. Bilateral abductor palsy, this is due to recurrent laryngeal nerve damage. Okay, next, bilateral adductor palsy, this is for the superior laryngeal nerve plus recurrent laryngeal nerve it is caused. But what is the nerve that is most common nerve in the thyroid is the superior laryngeal nerve, the external laryngeal nerve, then the internal laryngeal nerve. And same thyroid, if it is a bilateral, then it is the vagus nerve. So it will include the superior laryngeal nerve plus recurrent laryngeal nerve, right? So this is how the vocal cord palsy and their supply. Next, hepatitis markers. We have the hepatitis markers that is important. So the first is going to be the antigens, right? Antigens that is produced first are the hepatitis B antigen. Okay, this is tell us the patient is in the acute stage. Then followed by the hepatitis E antigen. This is also acute marker with high infectivity and also high replicity, high intensity, high replicity, followed by antibodies. So the recovery has been started. And the first one is the anti-HBC antibodies. IgM is for the acute, right? This is for the acute, and IgG is for the chronic, right? This is how they are going to see. And second one, anti-HBE antibodies. So that means this is a low infectivity and low replicity, right? Low replicity is seen in this patient. Next, third one, anti-HBS antibodies. So we might also have present this because these patients are vaccinated or these patients are cured. So the only one is present throughout the series. The one that will be present throughout the series, that is going to be the HBsAg. It will be present throughout entire life, present in whole life, that is the HBsAg. Next, how can you interpret? For example, acute HBe. Acute HBe, obviously hepatitis B, that is positive, and this is acute stage, so obviously infectivity is high, so there will be increasing of the HBeAg will be also present. Okay. Next, chronic type. Chronic patients, there will be increased IgE levels and HBsAg throughout the life it is present, and then it is the anti-HBe is going to be shown in these patients. Cleared HBV. What we discussed cleared HBV, there will be anti-HBs antibodies which will be present here. Vaccinated patients, anti-HBsAg is present. So this is how you are going to interpret this sick hepatitis markers. Next, moving on to the TB. Here you can see what is the TB organism that we have transmitted, guys. Mycobacterium bacilli. This is a Mycobacterium bacilli is present. How it is going to transmit it? With the droplets, right? Respiratory droplets it is going to cause. And after that, you are going to see this picture of the patient. What is this picture? So this is, you can see, this is a foci that is present, and this foci is known as a Gons foci plus bilateral lymph node involvement. There will be bilateral lymph node involvement, and this is how the patients with the acute stages will be presented. And what are the symptoms? The symptoms will be fever, low grade evening fever that is present in this patient, sweats, night sweats will be presented, and also weight loss. These are the classical carcinogenic type of the tumors. Next, cough plus sputum production. All these are going to give rise to the most commonly patients suffering from the condition of this one. This is the primary, but it can progress to the secondary. So secondary is known as a miliary TB. This is through the hematogenous spread through the blood. How can we do this patient's culture? This is a Lowenstein Jensen medium. With the help of the sputum, you are going to do. This is a liquid type. Okay, liquid broth that we are going to see in this patient. It will take around almost 2 months to come the results. This is a OPSIL procedure, and the best investigation for this patient is a CB-NAT. CB-NAT will be the best one because it is going to tell us about the importance about the usually resistance is also seen in this patient, right? That one. Next, another test that we can do is the Montauk's test. Montauk's test is also positive, and also interferon gamma, and in the rare cases we can also go for the biopsy. So biopsy will show the caseous granulomas, right? This is how it is going to be presented. Next, see this one. This is a Nikshay app. This is a Nikshay app for the TB patient. Don't confuse with the Nishchay. Nishchay is for the pregnancy. Nishchay is for the pregnancy. Next, this is the DOTS app. This is also for the TB treatment done by the ASHA workers. Update them. And this is the logo, TB Mukt Bharat logo. Right. Next, coming to the drugs, rifampicin. The mechanism of action is a DNA dependent RNA polymerase. Orange color body fluids is the side effect, and hepatotoxicity pulmonary syndrome. Isoniazid, it will inhibit the mycolic acids and cause the peripheral neuropathy, hepatotoxicity, SLE-like syndrome. Pyrazinamide, it is going to show the inhibit of the fatty acid synthesis, hyperuricemia, hepatotoxic. Ethambutol, it is going to cause the inhibition of the arbunyl transferase, and optic neuritis is going to be seen. And in the renal failure, it is contraindicated. Next, what are the resistances? So resistances, that question has been asked. Monoresistance. So what is mean by the monoresistance? Monoresistance means this is due to only isoniazid. Okay, this is due to isoniazid. Multi-drug. Okay, multi-drug resistance. This is due to isoniazid plus rifampicin. Okay, this is for the rifampicin. Multi-drug resistance. Polydrug resistance. Polydrug resistance is isoniazid and rifampicin is already resistant, plus they will be having plus or minus pyrazinamide plus or minus ethambutol. Okay, that is the polydrug resistance. Next, pre-XGR resistance. Pre-XGR resistance. This is other drug, that is a fluoroquinolones, or it is the extensive resistance. Extensive resistant isoniazid plus rifampicin plus fluoroquinolones, and also the bedaquiline is also resistant in this patient. So all this will be resistance that is seen in this extensive type of the resistance. Okay. Next one, that is a leprosy. Here you can see how the leprosy is classified. Leprosy is classified with a classification of the Ridley-Joplin. This is a Ridley-Joplin, right? So let's see the most common in India. The most common in India is the BT. This is the most common. Okay, and how the each one will be presented. So you can see this is the first one, tuberculoid. This is the hypopigmented and well demarcated, and the lesions are less than 1. Next, here the lesions are more than 5 lesions, and there will be satellite lesions. Okay, here you can see this is the satellite lesions, and borderline is going to have more than 10 to 15 lesions, more than 10 to 15 lesions, and it is going to known as a geographic lesions. These are the geographic lesions. Borderline lepromatous, this is extensive type, symmetric, nerve involvement is seen here, and also inverted saucer shape, and here this is the saucer shape. So saucer shape is seen in the BT, inverted saucer shape is seen in the borderline lepromatous. And this is the extensive type, lepromatous lepri, leonine facies, and more than 20 lesions, and more than 2 nerves involvement, right? Extensive type of the lepromatous lepro 1. Next, nerve involvement. Most common is ulnar nerve. Most common cranial nerve is the facial nerve. Most common peripheral nerve or the lower limbs, that is the common peroneal nerve. Okay, these are the nerves that is involved. Next, paucibacillary versus the multibacillary. Paucibacillary, that means the lesions are less than 5, and here the lesions are more than 5, and no nerve involvement here, and here the nerves are involved. And this patient's the treatment is 6 months only, and here the treatment is 12 months. 12 months. Okay, and what is the treatment of the choice for this patient? Treatment of the choice for this patient is the rifampicin followed by the dapsone and the clofazimine. Okay, so rifampicin patients, how much is the dosage? It is given 600 mg day 1. Day 1 it is given the 600 mg, along with on the day 1 300 mg on the day 1. Okay, only on the day 1 of the month starting. Next, dapsone. Dapsone is given 100 mg per day for 30 days, and clofazimine is 50 mg after from day 2 to day 30. It is given per day. Okay, this is how we are going to give. Rifampicin can cause the pigmentation. This is can cause the pigmentation. This is the PYQ. Okay, next, this is the logo, NLEP, logo of the national program, and a high chance this patient going to have the reaction that is known as a type 1 lepra reaction and type 2 lepra reaction. This is due to hypersensitivity reaction of third. This is due to hypersensitivity reaction of 1. Sorry, this is due to 4 guys, and this is due to 3. Third reaction. And this patient is having the neuritis. So painful lesions. Painful lesions. And the treatment of the choice is continue the drugs, continue the leprosy medications, and along with that you can give the steroids. And these patients, lepra 2 reaction, there will be extensive lesions, and erythema nodosum like reaction. And here treatment is continue lepra medications, and along with that you can give the thalidomide is given for this patient. Okay, this is the lepra 1 lepra 2 reactions. Next, coming to the vaccines. Okay, so vaccines that you have to remember is what are the live vaccines. Okay, what are the live vaccines? BCG, MMR. Okay, that means measles, mumps, rubella, all these are considered as a live. And yellow fever, is also one. And varicella. Okay, and polio virus, OPV, is the live one. This is the live vaccine. These are the some of the types of the live vaccines important. And live vaccines are contraindicated in pregnancy, and gap between the live vaccines is 4 weeks. General gap is 4 weeks between the live vaccines. And in patients like immunocompromised, you can give the live vaccines, plus you can also have to give the immunoglobulins for this patient, immunocompromised patients. Next, killed vaccines are hepatitis B, tetanus, pertussis, rabies vaccine, and also IPV. This is the IPV is also killed vaccine, and no contraindication for pregnancy. No contraindication for the pregnancy patients. Okay, and some are live plus killed. Live plus killed are polio. We seen that, right? Polio is live and killed. Japanese encephalitis both. Typhoid vaccines, flu vaccines, and the hepatitis A vaccines. Okay, these are the some of the combinations. Next, we have to maintain the cold chain. What is the cold chain? We have to maintain the freezing technique of the vaccines. How much is the degrees? Plus or minus 8 degrees Celsius is the maintenance of this one. Okay, this is how we are going to maintain the refrigerator for the vaccines. Okay, next here you can see 2 degrees to 8 degrees Celsius that we are going to keep here. And how we are going to keep BCG, measles, MR on the top shelf. BCG, MMR is in the top shelf because they are the freeze dried vaccines on the top shelf. And next, whatever the freeze sensitive vaccines, that is has to be in the downwards. Okay, how many days? It is 30 days, and it will be checked by the thermometer every day. 8 hours of the electricity is important. 8 hours of the electricity is important to avoid the damage to the vaccines, right? Next, moving on to the vaccines that can be given the route. The nasal vaccines is done by the flu vaccines. Oral vaccines are OPV and the rota. Intradermal is BCG and rabies. IPV vaccines. Intramuscular is, so wait guys, squamous. This is the subcutaneous, and here it is given by the measles, yellow fever, MMR, and remain all are going to be in the IM only, right? That one. Next, strains. BCG is having the Danish strain, Danish 1331, that is the one strain. Next, MMR, measles, is having the Edmonstone. Sorry with the spelling, just remember it is the Edmonstone. And next, mumps, which will be consisting of the Jerry Lynch. Okay, yellow fever is 17D. Rubella is RA27/3, and varicella is having of the Oka strain. Japanese encephalitis is having the 2 strains. Live is SA14142 and killed is Beijing. Killed is the Beijing type. Next, vaccine vial monitor. So if you see, the middle one is transparent and it is not mixing with the peripheral color, can be used, and this is also used. But if both are merged together, it cannot be used. And middle one, if it is more thick, this is also not absolutely used vaccines. Okay, this is cannot be used. And as we discussed, the vaccines can be having the side effects also. For example, OPV vaccine, it can cause the paralysis. OPV can cause the paralysis, especially P3 strain. P3 strain. So nowadays it is giving P1 and P2 strain only because P3 can cause the paralysis. Okay. Next, another one, flu vaccine can cause the Guillain-Barré syndrome. Measles vaccine can cause the tissue shock syndrome, and BCG vaccine can cause the osteolytis. Okay, osteolytis it can cause, plus lymphadenopathy, brachyitis can be seen with this patient. And the DPT vaccine, with the help of the pertussis, it can cause the seizures. The patient's rotavirus can cause the intussusception. Rotavirus can be causing the intussusception. And influenza vaccine is also contraindicated in the patients of the egg allergy. Patients with the egg allergy, it is contraindicated. Right, these are some of the important side effects. Next, vaccine part 2, that is a universal vaccination schedule. At birth, we are going to give the BCG, OPV 0 dose, and the hepatitis B birth dose. And 6 weeks, it is given OPV 1, pentavalent 1, rotavirus 1, and fractioned dose of the IPV 1 and the pneumococcal conjugate vaccine 1. 10 weeks, OPV 2, pentavalent 2, rotavirus 2. 14 weeks, OPV 3, pentavalent 3, IPV 2, and RBV 3, and the PCV 2. 9 to 10 months, you are going to give the MMR, JE, Japanese encephalitis, especially endemic areas, PCV booster. 16 to 24, measles vaccine dose 2, Japanese encephalitis 2, and the DPT booster, OPV booster is given. 5 to 6 years, DPT booster 2, 10 years, TD vaccine, 16 years, TD vaccine. Pregnant mother is also TD vaccine of the booster. How the pregnant mother is given? The first dose is given on the early pregnancy, and after the 4 weeks, you are going to repeat the dose TD2. Both are given in the intramuscular route. But if the mother is less than 3 years, you are not going to give, you can only give the booster dose for this patient. Okay. Next, upper GI, you have to understand, this is the Jenker's diverticulum. It is a farce diverticulum, right? It is present in the farce diverticulum. So these patients will be having the defect with the swallowing, right? And the location is at the Killian dehiscence. This is the location at the Killian dehiscence, right? And how we are going to treat this patient? The treatment for this patient is the diverticulectomy, or we also know this as a Dohleman procedure. Dohlam procedure. Next, another condition that you can see here, this is achalasia cardia. This patient is suffering from the achalasia cardia. And what is the cause? This is failure, right? Failure to relax. And what is this appearances that you are seeing here? Bird beak appearances. Bird beak appearances. And what is the treatment for this patient? Heller's myotomy. Heller's myotomy. Next picture that you can see here, this condition is the GERD. GERD is a condition, and in this patient, why it is important? It can progress to the Barrett's esophagus, and Barrett's esophagus can progress to the adenocarcinoma, right? Adenocarcinoma is seen in this patients, so that is danger. And for this patient, treatment, first we are going to treat with a PPI, okay? But if it is not controlled, then go for the surgeon. Then you can get the surgery of the meson fundoplication. Meson fundoplication is done for this patient. And diagnostic test, that is a gold standard, 24 hours pH monitoring. 24 hours pH monitoring is done for this patient. Next, another picture that you can see here, this is the Boerhaave syndrome. This is the Boerhaave syndrome. What is the Boerhaave syndrome? There is a rupture or perforation to esophagus. Perforation to esophagus, right? And that can cause the, in the alcoholics or binge vomiting patients is seen. and the treatment for this patient is open thoracostomy, and anastomosis, right? Repair. And complication is it can cause the pneumomediastinitis, pneumomediastinitis, Boerhaave syndrome. Next, viral inclusions. Intracytoplasmic Henderson-Peterson bodies are seen in the molluscum contagiosum. Negri bodies, here you can see these are the Negri bodies seen in the rabies. Gorneri bodies is seen in the smallpox. Paston bodies is seen in the smallpox. Bollinger bodies is seen in the fowlpox. Okay, intranuclear. Cowdrey type A is seen in the herpes simplex, varicella zoster. Cowdrey B is seen in the poliovirus. And Cowdrey B is adeno and the cytoplasmic. Here you can see this is the molluscum contagiosum, Henderson-Peterson, and this is the measles, giant cell types, and this is the Hodgkin lymphoma. These are the red Sternberg cells. Okay, and this is the CMV, is the owl eye appearances. Next, rickettsial diseases, typhus fevers. Rickettsia prowazekii is going to cause the epidemic typhus due to lice. Rickettsia typhi is the murine typhus due to fleas. Rickettsia felis is due to the typhus like fleas, and Rickettsia is going to cause a Rocky Mountain spotted fever. This is due to ticks. And Rickettsia parkeri tide white fever due to ticks. Rickettsia australiensis is a Queensland tick fever, again ticks. And the scrub typhus is the Orisha shishugamushi scrub typhus due to mite. Okay, these are the features, and here this is how the presentation will be seen. Rocky Mountain fever plus the rash, and rash will be diffused as you are going to see. Escher formation, this is seen in the scrub typhus. Rickettsia parkeri, you are going to see the lesions that is very prominent than the Rocky Mountain fever. And the drug of the choice for all this condition is a doxycycline. For this patient is the doxycycline that is given for this patient. Next, coming to the contraception, image based question that you can remember this one. What are the identification of this one? In the contraception, what is this one, guys? This is known as a lip is loop. These are the lip is loop, and here you can see this is the copper T380. This is the copper 380, where you are going to see arms and also body, both are covered with the copper. Next, this is the copper T75, and here only the body is formed. The arms are not covered with the copper. Okay. Next, another picture that you can see here. This is the Mirena. Mirena is hormonal, which will be present with LNG, right? And next, this is the rings, Graffinder ring, and this is also another type of the ring. And this one is the Antara. This is the Antara. Okay, and this is the centrochrome, which is also known as a Chaya. And this is the Mala N, which will be consists of the estrogen and the progesterone. These are the female condom, and this is the male condom, and these are the patches which will be having the less Pearl index. Less Pearl index is seen with this one. What is mean by the Pearl index? Recent INICT question. Number of failure pregnancies in 100 years of women. This is the Pearl index formula. Next, copper, right? IUCD, intrauterine devices, IUDs. Intrauterine devices is having the contraindications. What are those contraindications? Especially those who are suffering from the Wilson's, copper related is contraindicated. Patient is present with the PID or active infections, contraindicated. Abnormal uterine bleeding is contraindicated. If the patient is pregnant right now, this is also contraindicated. Or any uterine anomalies or uterine pathologies is contraindicated in this patient. Okay, and severe anemia is also contraindicated for this patient. Next, OCPs. OCP is contraindicated in the patients of the MI, cardiovascular diseases, cerebrovascular diseases, thrombus formations. This condition is contraindicated. And other conditions such as migraine conditions, liver disease patients, okay, liver disease patients is also contraindicated. Why? Because it is going to increase the breast carcinoma, it can increase the hepatocellular carcinoma, it can increase the thrombus formation. So that's why OCPs are contraindicated in these situations. Okay, this is the findings that you have to remember. Next, Duke's criteria. Duke's criteria is so important for the infective endocarditis, right? This is important for the infective endocarditis patients, right? Major criteria which will be involving of Positive blood pressure. Two or more blood pressures in the last 12 hours, it has to be positive. Or the three blood cultures, more than four separate blood culture, at least 1 hour gap from the each one. Or directly on the echocardiograph, if you see any growth on the valves, that is also considered as a major criteria. Next, minor criteria: fever more than 38 degrees, vascular phenomena like lesions, immunological phenomena, another nodes like lesions, one microbiological findings, or the predisposing heart condition or the IV drug abuse. This is minor criteria. If ever the confirmation will be two major criteria positive, or the one major, three minor, five minor criteria has to be positive, and possible infective is one major, one minor, and the three minor positivity. And what are the organisms that is involved in this patient? The most common overall, is the Staph aureus. The most common overall is the Staph aureus. Subacute type. Subacute type is the strep viridans, and patients with the chronic is the again strep viridans, which means more than 12 months. Next, in the valves, the patient is having the valves, normal valves, again Staph aureus. Patient with the prosthetic valves is also again Staph aureus. Prosthetic valves less than 12 months. This is seen with the Staph epidermitis. Okay. IV drug abusers. This is also going to due to Staph aureus. Okay. These are the organisms. Next, John's criteria. So John's criteria: patients rheumatic fever, low risk population and the high risk population. Major criteria: just remember the high risk because India is in the category of the high risk population. And the symptoms are carditis, arthritis, chorea, erythema marginatum, subcutaneous nodules. Minor criteria: monoarthralgia, fever, and increased ESR CRP level, and the ECG is showing the increased PR interval in this patient. And two major plus two minor has to be positive, or two major plus one minor can be positive, or one major, one minor, two minor. If any of this plus, you also have to show the ASO titers positive. Then only rheumatic fever is confirmed. And what is the treatment for this patient? IV penicillin is given for this patient. This is the drug of the choice for this patient. And prophylaxis. In the patients of the prophylaxis, for example, the patient is no carditis, then you can give the less than 5 years to up to 21 years. But the patient is having the carditis, so then you have to give less than 10 years up to 21 years, whichever the highest. Next, but patient is also having the rheumatic heart disease. Some valve is involved in this patient. Then more than 10 years up to 40 years you have to give. Okay, this is how prophylaxis is given for this patient, right? Next, moving on to the some of the lung disease and their scores. Curb 65. Curb 65, C for confusion 1 point, urea is more than 7 1 point, respiratory distress more than 30 1 point, systolic BP less than 90 by 60 that is 1 point, age is more than 65 years 1 point. Total we are going to give the 5 points. If ever 1 point is then outpatient care, 2 is the inpatient care in the general ward, and more than 3 is considered as a ICU and ventilation is needed for this patient. Next, gold criteria. Gold criteria is done for the patients of the COPD. Gold 1 is mild COPD less than 0.7 but more than 80% of the FEV1%. Type 2 is the moderate COPD 50 to 80 FEV1. Type 3 is the 30 to 50 and type 4 is the less than 30 is the you are going to see. Next, Berlin's criteria. This is known as a Berlin's criteria is done for the patients of the ARDS. Berlin's criteria, the patient has to be the prior presentation is less than 7 days only, and the pulmonary edema is a non-cardiogenic, it should not be from the cardiogenic, and the radiological features you are going to see the bilateral infiltrates, and hypoxia mild is 200 to 300 and moderate is the 100 to 200 and severe is less than 100. That is how FiO2 has to be noted. Light's criteria is for the patients of the pleural effusion, and in the pleural effusion, any one is present, then we have to consider this is due to exudation. If one is the pleural fluid and the serum protein is more than 5, pleural LDH and the serum LDH more than 0.6, and pleural LDH is more than 2/3. If any one is present, then it is considered as a pulmonary effusion or the pleural effusion. Liver diseases, and the MELD score is consisting of the bilirubin, INR, creatinine and the sodium. You don't have to know about the values. What are there present? Bilirubin, INR, creatinine and the sodium. Okay. Paroxysmal I am telling. So paracetamol toxicity and the non-paracetamol toxicity. This is also criteria that we are going to follow. This is known as a King's College criteria. This is known as a King's College criteria. Again, in the criteria, you don't have to know about the values. And the important points is, in the paracetamol criteria, you are going to see the pH and INR, serum creatinine, and is it the grade 3 or the 4 hepatic encephalopathy. And in the non-paracetamol, we are going to check the INR and then patient age, etiology, and time of the presentation, and INR, serum bilirubin is checked. What are the points that we are going to check? And last one, child Totok-Pug scale, and in this you are going to check encephalopathy, ascites, bilirubin, albumin and the prothrombin rate. Again, values and the numbers are not so important for this patient. Okay, that is the one thing that you have to remember. Next, coming to the ALT and SGPT and AST, SGOT, right? So ALT is important for the liver specific. This is only liver specific, whereas this one is liver plus muscle is going to be present. So viral hepatitis is going to show the ALT positive, and AST plus ALT is raised. Then it is seen in the patients of the alcoholics. There is a chronic one, that is a GGT, is again positive in the patients of the alcoholics, and 5 nucleotide, this is present in the cholestasis. And ALP is more important for the bile related disorders than the liver disorders. Okay, these are the points. Next, hernia. Hernia is divided into the direct inguinal hernia and indirect inguinal hernia. Okay, direct inguinal hernia and the indirect. And direct inguinal hernia is coming from the Hasselbeck's triangle, right? As I said, this is coming from the Hasselbeck triangle. So that means it is medial to the vessels. It is present medial to the inferior epigastric vessels, and no scrotum involved in this patient. Right here, it is coming from the lateral to the epigastric vessels, and this will be involving until scrotum. This will be considered until scrotum, and most common overall, it is present in the indirect hernia. And for the treatment, we are going to use the patient with the herniotomy, right? Herniotomy with mesh repair is done for this patient, right? This is how we are going to treat this patient. And the classification is Nihas classification. Type 1 indirect inguinal hernia, type 2 again indirect inguinal hernia with severe condition, type 3 is a posterior inguinal wall defect, so that means this is the direct inguinal hernia. Okay, 3A is the direct, 3B indirect, and 3C is the femoral type. Okay, fourth one is a recurrent hernia. That is a classification that you have to remember. Next, moving on to the ECG. First, we will be discussing about the two important ones. One is the sinus bradycardia. Sinus bradycardia is less than 60 beats per minute, right? Next, the most common one overall is the sinus tachycardia, which is more than 120 beats per minute, right? And this both conditions is just generally like whenever we are having the fever, inflammation in the body, or anxiety issues, or suddenly the collapse. All this will be presented with the sinus bradycardia or the sinus tachycardia. Next, if it is further extended, then we have the types of the bradyarrhythmias. The first one is the first degree heart block. What happens in the first degree heart block? There will be PR prolongation, right? PR prolongation more than 120 milliseconds. Then if it is more than 120 milliseconds, it could be even more than 200 milliseconds. That is a PR prolongation. But PQRS and T wave, everything is present in the first heart block. Next, second degree heart block, and here also there will be increased PR prolongation, but sudden QRS drop. There will be sudden QRS drop. So here you can see there is prolongation, 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 and suddenly there is a drop. So that is what the second degree heart block, Mobitz type 1 or the Venke back. Next, second degree heart block, Mobitz type 2. Here PR is normal. PR is normal, but there is a drop of QRS. QRS drop is seen. Here you can see this is normal, 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 and sudden drop. So this is what's seen in the third degree heart block. And the fourth degree heart block, second degree AV block, this is a 2.1. Sorry, this is the still second degree heart block only. And third one, this is the third AV block, and we can say this is the complete block. Complete block. Why it is a complete block? P block and the QRS, P wave, QRS. So there is no relation between at all. So it is going to simultaneously gives rise to the different types. So that is what we are going to see in this patient. So what is the treatment? So treatment for this patient is the atropine or underlying cause. Here also treatment is atropine. But in the patients of the Mobitz type 2, it is severe, so we have to go for the pacemaker. Pacemaker is the only treatment. And also complete heart block, the treatment is only depends on the pacemaker. Right? Next, moving on to the ECG, another types. So you are looking at here is the tachycardias. So tachyarrhythmias. So here you can see this is an irregular baseline with the absent P waves. So this is the condition of the atrial fibrillation. So this patient is atrial fibrillation. If the patient is unstable, go for the cardioversion. But let's say that the patient is stable. Before you decrease the heart rate, look for the echocardiography. If ever the patient is having the clots, then you have to give the dual antiplatelet therapy. Okay, dual antiplatelet therapy plus amiodarone has been given for this patient to control the heart rate. Next condition that you can see, there are the three different types of the P waves that you are seeing here. So this is known as a multi-atrial tachycardia, and seen with the COPD patients or patients who is suffering from the theophylline toxicity. And the treatment for this patient is beta blockers to decrease the heart rate. Next, here you can see this is a sawtooth appearances, but the P wave is present. P wave is present. This is known as a atrial flutter. This is the atrial flutter condition, and in this patient we are going to give the patient treatment of the beta blockers. Beta blockers is given for this patient. Okay. Next condition that you can see, this patient is having the regular interval, right? It is regular interval, but the P wave is absent at regular intervals. This condition is known as a supraventricular tachycardia, most commonly seen with the children. For this patient, the first line is the maneuvers, okay, vagal maneuvers that we are going to perform. If it is not controlled, then drug of the choice for this patient is the adenosine. Adenosine is given for this patient. And if the patient is unstable, then again we are going for the cardioversion for this patient. Next, moving on to the some other conditions that you can see here. The conditions that are present here, you can see there is a presence of the delta wave and short PR interval. Short PR interval. This is the Deplu Wolf Parkinson White Heart syndrome. Wolf Parkinson White Heart syndrome. And for this patient, the treatment is ablation of Kent. Okay, you have to remove that. But the drug of the choice is the prokinamide. Prokinamide is a drug of the choice for this patient. Okay. Next condition that you can see, this is a VT, ventricular tachycardia. Ventricular tachycardia, patient is having the pulse. Then you can go for the defibrillation. Sorry. Then we can go for the drug. So drug can be given amiodarone. But unfortunately, the patient pulse is not present. Okay, pulse is not present. Then you have to go for the defibrillation. And here this is a torsades de pointus. So increased Q interval can progress to the torsades de pointus. This is a torsades de pointus, and highly the patient can die. For this patient you have to give the IV MGSO4, and here this is a V fibrillation, and for this patient also defibrillation has to be done for this patient. Okay. Next, moving on to the valvular heart diseases, and also you have to remember about the how we have to treat this patient. So this is a stenosis patient, open stenosis and the closed stenosis. the patient conditions. So first you have to understand the cardiac cycle. Isovolumetric contraction followed by the rapid ejection and slow ejection. Okay, so in this phase, this is the systolic phase, right? So systolic phase, what are the valves are open? What are the valves that is open here in this place, guys? The sound that you are going to get in the S1, right? S1 is due to aortic and the pulmonic and tricuspid and also mitral valves. So this is a close and this is open, right? Because ejection is happening through the aortic and pulmonic, right? So during the S phase, if there is a stenosis, so the stenosis will be seen in the aortic and the pulmonic, and the regurgitation is seen with this closed one, that is the tricuspid and the mitral. So now tell me, which are the systolic murmurs? So systolic murmurs are aortic stenosis, pulmonic stenosis, mitral regurgitation and the tricuspid regurgitation, right? So this is clear. Next, moving on to the isovolumetric relaxation and rapid filling followed by the slow filling, seen with which phase? This is a diastolic phase, right? And S2 is produced here. So here aortic and the pulmonic valves are closed because ejection is done. So this is the closed type, you are going to get the stenosis, right? Sorry, in the closed you are getting the regurgitation. Next, tricuspid, you have the tricuspid followed by the mitral, both are open, is going to cause the stenosis. Right? So now tell me, in the diastolic murmurs are aortic regurgitation, pulmonic regurgitation, mitral stenosis and the tricuspid stenosis. Right? These are the diastolic murmurs and the systolic murmurs. Right? Easy, right? So this is how you have to remember. Next, some of the murmurs that you can see here. Aortic stenosis. What is the murmur that is coming, guys? This is the systolic phase or the diastolic phase. This was the systolic phase. So you are going to see the systolic type of the murmur. Next, pulmonic stenosis. Pulmonic stenosis is seen as this one. Again, this is the systolic murmur that is going to be presented, right? Both are known as a systolic type of murmurs. And mitral valve prolapse. Mitral valve prolapse, you are going to have click. This is the mid click that you are going to hear. And after the mid click, you are going to have the late systolic murmur. Late systolic murmur. And patent ductus arteriosus. This is going to show the continuous murmur. This is going to show the continuous murmur. And atrial septal defect, there the S2 split with systolic murmur. S2 split with the systolic murmur that you are going to see. And in hypertrophic cardiac myopathy is also going to show this murmur, which is known as a systolic murmur. Mitral regurgitation, this is holosystolic murmur. This is the holosystolic type of the murmur, and the tricuspid regurgitation is also holosystolic type of the murmur. Then the VST is having the complete holosystolic murmur. This is also holosystolic murmur, right? These are the murmurs that you have to remember, right? And importantly, these are the points that is frequently asked in the examination, right? You just follow this. Systolic murmurs, whichever is opening during the systole is going to cause the stenotic murmurs, whichever is closing is going to cause the regurgitation. If you apply this formula in the examination, as much as I say, it is going to be no wrong for your examination. Next, moving on to the ABG, how you are going to perform the ABG? Through the blood sample, and before the blood sample taking, you have to do this test. This test is known as a modified Allen test. This is the modified Allen test. You are going to occlude the ulnar side and also on the radial side. Once you are occluded, release one hand. If you see the perfusion to the hand, that means you can proceed for the radial artery sample. Okay, that means collateral supply is seen for the hand, so that there is no formation of the ischemia. Next, let's move on to the how to interpret the ABG. First, you're going to check the pH levels. pH levels normally is 77.4, normal pH. Then you are going to check the PCO2, which is 40 mmHg, and HCO3 bicarbonate is checked. This is a 24 milliequivols that you are going to check. And this is just average, guys. Normal, I am telling. average only. Okay. Next, if the respiratory acidosis, first you check the primary. If the pH is low, then it is a acidosis. Then all the respiratory conditions will be opposite to the pH levels. So PaCO2 and the HCO3 will be elevated in the respiratory acidosis. And in the respiratory alkalosis, alkalosis means primary disorder is pH is raised. Then the PaCO2 and the HCO3 will be decreased. So this is how respiratory conditions will be seen. In the acidosis of the metabolic, there will be decreased. All the levels are decreased in the metabolic acidosis. All the levels are elevated in the metabolic alkalosis. So this is how we are going to interpret, right? Next, how can we check the compensation? How can we check the compensation? Remember the simple formula for the compensation. First, there is no compensation. Sometimes there is no compensation. And in the no compensation, the patient pH will be decreased, acidosis, and so as the HCO3, because this is the metabolic condition, HCO3 will be also decreased. And for this metabolic, what has to be compensated? Respiratory, but the respiratory is here normal. So there is no compensation is happening from the side of the respiration. Next, partial compensation. In the partial compensation, pH was low and the HCO3 is also low and the PCO2 is started the compensation. This is going to show as low. So all the levels is deranged, then it is a partial compensation. Next, fully compensation. Compensation has been done. If the compensation is done, that means pH has to come to the normal. So pH will be coming to the normal. HCO3, it still is going to recover from that, and the PCO2 is compensating to get this HCO3 to the normal levels. Okay, so this is the compensation formula that you have to remember. Okay, next one, anion gap. Anion gap is always associated with the metabolic acidosis. Okay, anion gap is associated with the metabolic acidosis. So you have the high anion gap and you have the low anion gap, normal anion gap with the metabolic acidosis, right? So let's see the condition. So especially in the patients of the RTA or the patient who is suffering from the diarrhea, okay, and also those who are taking the diuretics such as spironolactone drug and the saline infusion, all this is going to show the normal anionic gap. And here the patients who are alcoholics, who are taking the poisons such as glycol poisoning, or those who are taking the methanol, Hooch tragedy, or taking the drugs such as salicylates, patients with the lactic acidosis or the DKA, diabetic ketoacidosis, they're going to show the increased anion gap that will be seen in these patients. Okay, next, glutes. Glutes question that has been asked in the previous examination. Let's remember the glutes. So glute 1, 2, 3, 4 and 5. These are important. Okay, first one, RBC and brain, RBC and the brain. Next, second one is seen with the liver, kidney, and also important one is the pancreas, right? Next, third one is brain but neurons. Okay, this is for the neurons, and also spleen and for placenta. Okay, and here you can also remember retina. Next, fourth one, this is highly important because this is insulin dependent. This is the insulin dependent. Here you have the muscle, fat, also heart. And the fifth one is for the intestine. Fifth one is for the intestine, and this is fructose dependent. This is the fructose dependent, right? One point that is important. Next, SGLT2. You also have the SGLT1, SGLT2. 2 is for the kidneys, so present in the PCT, kidney, and 1 is for the intestine, followed by the PCT. So PCT is consisting of the 1 and 2. Next, SGLT2 mechanism is done for the ORS rehydration is through this one only. Okay, another point that you have to remember. Next, LDH. LDH. LDH is present in the heart. This is the LDH type 1. Next, LDH type 2 is present in the blood cells. This is the type 2 LDH. Next, LDH3 is present in the lungs, pancreas, okay, and liver, and also lymph nodes. This is the third LDH. Fourth LDH is more prominent in the liver, and fifth LDH is more prominent in muscle. This is the fifth type. Okay, this is the LDH types. Next, creatinine. Creatinine BB is present in the brain, and BM is present in the heart, and MM is present in the muscle. Okay, MM is present in the muscle. Next, glycosaminoglycans. First one, the most common, is the chondrine sulfate. Okay, chondrine sulfate. This is present in the cartilage. This is present in the cartilage and in the bones. Right. Next, heparan sulfate. Heparan sulfate is present in the kidney. Heparan A. You also have the heparin. This is the anticoagulant. Is formed by the glycosaminoglycans. Keratin sulfate is present in the cornea for the transparency, and the dermatan sulfate is present in the skin and also in the vessels, and the hyaluronic acid is present in the synovial fluid and also vitreous humor. Vitreous humor. It is present, right? So this is the dermatoglycans. Next, collagen. Collagen type 1 is seen in the skin and also in the bone. Type 2 is seen in the cartilage. Type 2 is seen in the cartilage. Type 3 is seen in the vessels, arteries, and the fourth one is seen with the basement membrane. Okay, basement membrane of kidney. So these are the collagen. These points can be asked, guys. Please don't miss them. Next, epidemiological studies. Epidemiological studies, as we discussed, cohort study. So for example, you have took the cases and also no cases, right? So patients. So you are looking at the population. For example, let's take the population that you have took these patients. So two populations groups you are going to take. One is exposed, one is non-exposed, right? Non-exposed. So both the patients, both the patients is having the risk factors, right? And you are looking at for the future, and in the future you are going to say whether they are going to develop the disease or whether not going to develop the disease, right? So you are looking at the future. This is known as a cohort study. This is known as a cohort study. And the factors that you are going to calculate here is the relative risk. How much is the relative risk and how much is the incident for the new cases, okay? And population risk and population attributable risk. All this will be decreased seen in the patients of the conditions with the cohort study. Next, case control study. So for example, this patient is diseased, this patient is no disease, and disease is present. Why disease is developed? You are going back and checking for the patient risk factors, and why this patient is not developed. So you are going to check the risk factors. You are going on to the past side. So this is are the cases and these are our controls, right? So you are going to the past of these two is known as a case control study or retrospective studies. And here you are going to calculate for the odds ratio. You are going to look at for the odds ratio and also for all the rare diseases you are going to see. For example, let's say COVID-19 is seen in the Wuhan disease. What we have done, we have gone back and what happened to that patient, we have checked. So that is what, that is a factor that you have checked in the case control studies. Cross-sectional study, ecological studies, these are done at the same time you are going to look at. And cross-sectional study is for the prevalence. How many are the new cases, how many are the old cases, that you are going to see in the case control, sorry, cross-sectional studies. And ecological studies is done in the population. Over the population you are going to do the ecological studies, right? This is the ecological studies that you are going to do. Next, moving on to the pemphigus disorders, you have the pemphigus vulgaris, which is the most common overall, and the pemphigus foliaceus. What are the desmoglins that is affected? In the vulgaris, desmoglin 3 and the desmoglin 1. In the foliaceus, it is a desmoglin 1. Why is the desmoglin 3 is involved? Desmoglin 3 is involved means, that means mucosa is involvement. So vulgaris patient is having the mucosal lesions, and also outside there is a blister is present in this patient. Nichols skin is present in both of those patients. And on the histopathology, there is a suprabasal layer acantholysis. Here you can see this is the suprabasal layer damage, and also IgG of net like on the immunofluorescence you are going to see. And the treatment for this patient is rituximab, and the steroids is given for this patient. Okay. Coming back to the foliaceous patient, there is a scaly lesion which is a superficial lesion, and there is no mucosal involvement. So differentiating factor is no mucosal involvement and acantholysis of the subcorneal layer. And same fish pattern is seen, and milder condition, topical steroids is enough for this patient. Next, there is a condition that you can see. This is a bullous pemphigoid. Bullous pemphigoid is seen in the old people, and especially these patients are affected with the bullous pemphigoid 120 is affected, and also that is the other factor 230 is affected in this patient. So the antibodies is going to kill 120 and the 230 genes is affected in this patient. But this bulla is very tense bulla. This bulla is looks like such as tense bulla, and Nikolsky sign is negative in this patient. And on the immunofluorescence, you can see there is a prominent of the dermoepidermal junction. Dermoepidermal junction is more prominently seen in this patient, and the treatment for this patient is the steroids. Next condition that you can see, the child with the gluten sensitivity. Gluten sensitivity is seen in this patient, and this condition is known as a dermatitis herpetiformis. This is the dermatitis herpetiformis is present in this patient. Okay, and the condition, this one is a celiac disease. Celiac disease, and the treatment of the choice for this patient is dapsone can be given, and also you can stop the gluten-free diet. Gluten-free diet is also given for this patient. Next condition, hair disorders. Hair disorders, this can be potential question, guys. First, let's see telogen effluvium. Telogen effluvium, and another one is the anagen effluvium. Anagen effluvium. So patients suffering from the telogen effluvium associated with the infection or stress. Anagen effluvium is mostly due to radiation. So cancer patients, right? And both are reversible. Both are reversible. Next, another one is the male pattern. Male pattern or female pattern. So this is a gender related. Obviously, the male pattern is due to increased testosterone, which is converted as a dihydrotestosterone. So which is due to dihydrotestosterone. And the treatment of the choice for this patient is the finasteride. Finasteride and minoxidil is given for this patient, right? Next one, alopecia areata. Alopecia areata. So this patient is having the autoimmune condition, and here the treatment is steroids, and the hair loss is patch-like loss. And if you look at this under the histopathology, you are going to see the exclamation mark. Okay, exclamation mark is seen. Next, trichotillomania. Trichotillomania is type of OCD condition. This is a type of OCD condition. Hair picking. So the patient will be hair picking. And if this hair is ingested, so if the hair is ingested, so the patient is known as a trichophagia, right? This condition is trichophagia. And after that, if you see this under the obstruction, bowel obstruction, this is known as a trichobizar. This is known as a trichobizar. It's a psychiatric cum surgery cum dermatological condition. Next, acne. Grade 1 is a mild one. Comedons is present in this patient. The treatment is topical retinoids. Grade 2 is a moderate one. Comedons, papules and the pustles is treated with the retinoids and the topical antibiotics. Grade 3 is going to be the pustles and extensive inflammation. This patient is needed with a topical retinoids plus oral antibiotics. Grade 4 is a severe condition. It has to be treated with the oral isotretinoin. Next, psoriasis. Psoriasis, you have the different types. One is the most common is a plaque psoriasis, and it is seen on the extensor surfaces, guys. and it is going to show as a silvery flakes. And next one, gutted psoriasis. This is associated with the triggered by the infection and multiple papules and the small lesions that will be seen on the trunk, typically present with the children. Inverse psoriasis in the inverse locations like flexor locations like armpits, inguinal regions and inframammary regions. You are going to see red smooth color shiny lesions is seen. Pustular psoriasis, this is an extensive pus and non-infectious. Patient will be having the fever and chills. That is a pustular psoriasis. Another one is a erythrodermic. This is the extensive widespread type of the lesion that is going to be seen, and life-threatening complications also seen. And the nail psoriasis, you are going to see here the nail condition such as the patient is having the pitting, ridges, discolorization that you are going to see. Here you can see irregular pitting, leukonychia, the color changes, red macules, crumbling, trichonychia, and also splinter hemorrhages and the hyperkeratosis, Salmon patch or the oil spot. So you can see this is the oil spot, pathognomic sign, and the onycholycosis. And next, under the lesion, if you can see, while the lesion is bleeding, that is known as a Auspitz sign. This is known as a Auspitz sign, and this test is known as a Garrett test. This is the Garrett test. Next, on the X-ray, you are going to see subperiosteal resorption is seen in the psoriatic arthritis patients, right? Next, moving on to the placenta. Placenta is having the two sides. One is the maternal side and other one is the paternal side, sorry, fetal side. On the maternal side, it is 1/5 of the placenta, and that is a decidua basalis. Okay, this is a decidua basalis. And 4 times of the placenta is chorion fundosum. It is a fetal component. Next, the types of the placentas are battledore. Battledore means insertion is at the corner. And the circumvallate, there is a thick maternal content. And the biparpate and the equal two lobes is seen. Filamentous is it is not inserted in the placenta, rather than it is inserted to the chorion. And the circummarginate, you are going to see this like thick valve that is seen surrounding, and the succinturate lobe is going to have the small lobe comparing to the extra lobe, right? Come again, see here, this is a multi lobe, two lobes is seen, and here succinturate lobe, the small lobe plus big lobe is seen. Circumvallate, there is a thick type of one which will be seen. Velamentous are the marginal battledore. This is the velamentous which is attached to the chorion, and the velamentous is in the corner type. This is the placenta type. Next, the next we are looking at the gestational hypertension or the hypertension in the pregnancy patient. So this is divided as a gestational hypertension disorder, or patient is suffering from the pre-eclampsia, patient is suffering from the chronic hypertension, or superimposed pre-eclampsia plus chronic hypertension patients. How this is presented? Let's see. The patient who is presented with a chronic hypertension, they are pre-hypertensive before the pregnancy plus post-hypertensive. Postpartum also, this patient is having the hypertension, right? This is the chronic hypertension. Next, gestational hypertension is more than equal to 20 weeks that the patient is having the BP. How much is the criteria? 140 by 90 mmHg. Plus, there is no proteinuria. There is no proteinuria is seen in this patient. Pre-eclampsia, again 20 weeks. Okay, and the criteria is more than 140 by 90 mmHg, but there is a proteinuria. That is what the pre-eclampsia. And coming to the superimposed type, so superimposed types is nothing but the patient is pre-hypertensive plus patient is having the proteinuria. So this is the features with the pre-eclampsia features, that is the PIH superimposed. And how can we treat this patient? What are the risk factors? So the pathology of this condition is placenta abnormality. Okay, placenta and its circulation is causing the pathology of this condition. So what are the conditions that will be associated? Especially abruptia, or patient is having the previous history, patient is having the twins pregnancy, patient is diabetic mellitus, or patient is having the RH abnormality, patient is having the placenta abnormalities, right? And early age and paternity genes and family history, all these are going to play a role in the risk factors of this development. But can we prevent this? Yes, we can prevent with the aspirin drug. 100 mg, we can start this patient around the 12 weeks of the pregnancy AOG. We can start this patient. Okay, and contraindicated is ACE inhibitors should not be given. It can cause the renal defects in the baby. Okay, so as a herbs, this is also not given for this patient, right? Next, what we can be given for this patient? So the drugs that we can give for this patient is the labetalol, or we can go for the hydralazine and alpha methyl dopa. This is one of the safest drug. And another drugs, if the patient is asthmatic, we can go for the alpha methyl dopa and IV sodium nitroprusside, sodium IV nitroprusside and nifedipine is given for this patient, right? This drugs is also given for this patient. Next, so there is a eclampsia. Eclampsia is a condition is associated with the seizure plus hypertension, right? For this patient, the treatment is IV MgS44 plus IM MgS44. This is known as a pre-charts regimen that we are going to give for this patient. And the best treatment for this patient is terminate the pregnancy, termination of the pregnancy. Another complication is the HELP syndrome. HELP syndrome is also treatment IV MgS44. Best treatment is termination of pregnancy. Termination of the pregnancy is done for this patient. The overall delivery of this patient, if the patient is mild gestational hypertension, then we can go for the patient at least 37 weeks of gestation we can take, and then you can go for the induction of the labor. But let's say that the patient is having the severe condition and patient is having the pre-eclampsia with severe features, or patient is having the HELP syndrome, patient is having the seizure. All these patients, regardless of their gestation, regardless of age of gestation, termination of the pregnancy has to be done. You can go and remove the pregnancy immediately. This is how we are going to treat the PIH of the patient. Next, moving on to the abnormalities such as APH patients. So this is the antepartum hemorrhage. First one is the previa. So previa is having the grades. You can see grade 1 is marginal less than 2 centimeters. This is less than 2 centimeters, and this is the marginal type, and this is the severe type, and this is half close, and it is fully close os, fully close the os, right? These are the four categories. How you are going to treat the patient? So how the patient will be presented? Painless condition, right? Patient is having the painless bleeding and no tenderness, right? Mostly this is how the patient will be presented. Next, let's say that the patient is unstable, or baby fetal heart rate is at the distress, then you can terminate this pregnancy. Okay, terminate this pregnancy, go for the cesarean section. And remember that contraindicated intravaginal, sorry, contraindicated per vaginal or the per speculum exams in this patient. Okay, next, the patient is stable, then you can go for the McAfee. This is the McAfee Johnson regimen. That means you have to make sure that at least the patient is more than 34 weeks of gestation, 34 weeks of gestation, 34 weeks of gestation to maintain until 37 weeks of gestation. Okay, with the help of supportive therapy. How can be the supportive? You just monitor the pregnancy and have to maintain the fetal outcome and lung maturity with the help of the steroids. You have to maintain, and then delivery can be done by the supportive. And here also the choice is lower cesarean section only, because vaginal delivery is contraindicated because potential bleeding can be seen in this patient. Okay, next, abruptio. In the abruptio, this is going to be the painful bleeding. So the mother is having the painful bleeding, abruptio patient, plus tender abdomen. Tender abdomen is also seen in this patient. Okay, let's say that the mother is stable more than 34 weeks, then you can start the induction of the labor. Okay, induction of the labor can be done. Next, 34 weeks, you can expect the delivery, expectant management. But the mother is unstable or the fetal distress is seen, then you have to terminate. And the termination here is always vaginal only. It is vaginal. Even if you see fetal death, then also vaginal only. Unless or until if the mother is having the DIC and severe instability, severe hemodynamic instability, then you have to go for the cesarean section. Okay, cesarean section is done for this patient. Next, vasa previa. So what the vasa previa? This is severe condition. Why it is a severe condition? Because it is a fetal blood loss. It is a fetal blood loss, and fetal must be in the distress, right? To prevent this, the treatment is termination of the pregnancy. Immediately, the termination of the pregnancy is done, and that also with the help of the cesarean section. NVD is contraindicated in this patient. Next, patients with the percreta, accreta, and the increta, right? So, accreta means when the placenta is attached to the uterine wall of the myometrium, okay, and the increta is more myometrium. Sorry, here you can see this is the percreta, right? So the patient with the accreta, it will be including of the endometrium plus myometrium. Okay, increta is only the myometrium. Percreta, myometrium plus bladder involvement. What is the cause of this patient? Cause of this patient is most common risk factor. The patient is having the history of LSCS and then present pregnancy with previa. Present pregnancy with previa. This is the most common risk factor. And the cause is there is a Nita Butch layer. Okay, Nita Butch layer is present in the placenta and this is absent in the patients of the percreta. So that there is a condition. And the treatment of the choice for this patient is LSCS for this patient. And if the patient is having the complete family, then we can go for the hysterectomy. Hysterectomy is done for this patient. Next, PPH. So PPH patients, the most common and important one is the uterine atony. Okay, this condition is uterine atony. How you are going to treat the patients with the uterine atony? Let's see step by step. For example, the patient is having the bleeding immediately after the delivery of the baby, right? So first you have to maintain the ABC, right? Airway, breathing, circulation has to be stable for the patient. Then start to control the patient with the help of the massage. Okay, by manual massage has to be done for the uterus. But despite of this, it is not controlled. So along with this, you have to start the uterotonic drugs. You have to start the uterotonic drugs to relax, such as oxytocin is given for this patient and methargin is given, carboprost is given, okay, and also misoprost is given for this patient to control. Okay, but still it is not controlling. Still it is not controlling. Then you can enter the Bacry balloon catheter, which will be filled with the 500 ml of NS and put the pressure inside the uterus. But still it is not controlling. Then you apply the pressure sutures. These sutures are known as a B-Lynch sutures. This is known as a B-Lynch suture. For example, this is our uterus, right? So suture like this. Tightly pack the uterus into this sutures. But still it is not controlling. Then go for the ligation of arteries. Okay. For example, start with the uterine artery. Okay, still not controlled, then go and block the ovarian artery. Still not controlled, then go for the internal iliac artery. Internal iliac artery is blocked. Anterior division. Still not controlled, subtotal hysterectomy. Okay, subtotal hysterectomy is done for this patient. This is how we are going to treat the patients with the PPH. This is how we have to treat the patient. Next, uterine inversion. Uterine inversion. That means uterus is came back. How can we treat this patient? First, try to stop the patient. Okay, stop the patient uterotonics. That means stop the oxytocin. Then start the terbutaline. Start the terbutaline. This is relaxation, right? Next, after that, you are going to place this manually. Manually, send manually. You can do. This is known as a Johnson's technique. Johnson's technique. And after that manually placement, if you can place, that is good. Then you can start the oxytocin to relax and stop the terbutaline. Okay, that is fine. But if the manually is failed, is failed, then go for the surgery. Then go for the surgery for the patient. So this is how uterine inversion is treated. Next, uterine hematoma. Uterine hematoma. This is aspiration. Incision and drainage or aspiration is done to prevent the tension, right? Next, Parkinson's disease. So the patients who is suffering from the Parkinson's disease, there will be more than 60 years of old, right? Mostly elderly people, they will be having this condition. And in this patient, the dopamine levels are decreased. Dopa levels are decreased in this patient. Okay, and it could be associated with the chromosome 4, chromosome 6. Okay, chromosome 4 is autosomal dominant, chromosome 6 is autosomal recessive patient. Okay, mostly senile patients will be presented, and males are more prone than the females. This is the Parkinson's condition, and Parkinson's patients will be having the conditions such as akathisia, problems with the voluntary and the involuntary movement, and decreased movements is seen. Patient can develop the dementia. Patient can develop the tremors, and the tremors such as resting tremors, resting tremors. And patient is also having the problem with the gait abnormalities also seen in this patient, right? Under the microscopy, you are going to see this Levy bodies. Okay, Levy bodies is seen in this patient. Along with that, there will be also seen with the alpha syncline. Alpha syncline is also seen in this patient. Okay, so this is a gait abnormalities, shuffling gait or the taking small steps, that will be seen in this patient. Okay, and next, coming to the treatment, how you are going to treat this patient. The best drug of the choice for this patient is the levodopa, but levodopa is having the severe side effects. So to prevent these side effects, we are going to add the carbidopa. This is added with the carbidopa as a combination therapy for all the patients. And also we are going to add the MAO inhibitors, and these MAO inhibitors are such as selagelin. Okay, selagelin. If it is a drug induced Parkinson, then benzatropine is given for this patient. Okay, benzatropine is given for this patient. Okay, and also encopate drug, encopant drug is also given for this patient. This is the Parkinson's overview. Next, Alzheimer's. Alzheimer's is a condition, again elderly patients, and males are more prone than females, and Down syndrome babies, right? And whoever is suffering from the trisomy 21 or the mutation to the chromosome 21, right? And amyloid deposits, right? Amyloid A beta is going to cause this one, right? All these are considered as a Alzheimer's condition. And decreased acetylcholine, decreased acetylcholine. And here you can see this is seen in the cortical atrophy. You are going to see the cortical atrophy on the patient. And when you do the histopathology, you are going to see these pictures. These are known as a tau proteins. These are known as a tau proteins, and these are known as a amyloid proteins. Okay, amyloid proteins, and these are neurofibrillary tangles. These are seen under the microscopy of the pictures. Alzheimer's patient. Okay, how can you treat this patient? So the treatment for this patient is always going to increase the acetylcholine levels. That can be done by the drug of the choice, donepezil, okay, rivastigmine, and you can also give the NMDA blocker, that is amantadine, sorry, memantine. Okay, memantine is given. Here also you are going to give the NMDA. Okay, that is the amantadine. So these are the drugs that we are going to give in the patients of the Alzheimer. So this is the treatment for the Alzheimer's. Next, breastfeeding. How the proper breastfeeding is done? The patient has to be correct. Completely the areola has to cover. Okay, areola has to cover, and lips are flanged out of the baby, and upper areola can be seen smoothly. Okay, that is that. How many months is a breastfeeding? Exclusive breastfeeding has to be done for the 6 months. Okay, this is considered as a exclusive breastfeeding, right? Next, more than 6 months plus until 2 years, you have to give the breastfeeding plus complementary food is given for the baby, but 6 months is mandatory for the baby regardless of the condition. Then what are the patients are contraindicated? Absolute contraindications, such as absolute contraindications, especially the mother who is taking the chemotherapy or the radiotherapy, because these toxic materials can go into the baby, that is contraindication. And baby who is suffering from the galactosemia, and mother who is, sorry, again baby who is suffering from the lactose intolerance, we are contraindicated. Next, relative contraindications is HIV severe cases. Okay, in severe immunocompromised patients, HIV is contraindicated, and those who are taking the TB therapy or not have even started. No TB therapy has been started. This patient is also contraindicated. Herpes lesions on the breast, areola region, we will be contraindicated, and CMV babies. This is also contraindicated. Next, this is the colostrum. This is the colostrum, and this is the breast milk, transition milk. So, in the first 1 week you are going to see this colostrum. How does the colostrum is looking? Yellow, and this will be thick, fatty, and increased IgA levels to help the baby from the infections. And the milk, transition milk, this will be white, right? And it has the equal parts of the protein, fats, and also carbs that is present here. Okay, that is the patients with the transitional milk. Okay, next, how the babies are having this one. Okay, milk is going to come with the two hormones. One is milk ejection, okay, and also there is a milk suction. Milk suction is due to prolactin, milk ejection is due to oxytocin. Okay, that is the present. Next, sucking reflex. Sucking reflex is present more than 35 weeks. Okay, this is more than 35 weeks. So whoever is born less than 28 weeks, they doesn't have the sucking reflex. So we are going to give the total parenteral nutrition IV. 28 to 31 weeks NGT or the OGT via, and more than 32 weeks is paladile spoon, katori spoon, right? And whoever is more than 34 to 35, then they can go for the breastfeeding of the babies. That is done for the babies. Next, what are the contents that is present in the breast milk? It is going to have the rich IgA levels, and it is having the vitamin A levels, and also lactoferrin levels. Okay, lactoferrin levels, and casein protein. Okay, it consists of the casein, whey protein, and whey protein is more 60%, and this is around 30% of the casein protein. Okay, and fats such as DHA, docoxy, and also PUFAs, all this will be important for the brain and neurons development. And iron is low, but iron absorption is high. Iron absorption is good. Okay, bioavailability is good, and bifidus factor bifidus factor to prevent the infection, GI infections, and also there is a lactose for GI health. GI health, there will be lactose also present. And vitamin C is normal, whereas vitamin D is decreased in the breast milk, right? And how many hours we can store? For the 6 hours, you can store at the room temperature. For 24 hours in the fridge, general fridge, you can store. More than 3 months, you have to store in the minus 2 degrees Celsius. Has to be stored for the 3 months of the storage, right? Next, moving on to the malaria, how the malaria is given for the patients. Okay, first, the Vivax patients in all the states, you are going to give the chloroquine, regardless, northeastern, south, north, west, any area, you are going to give the chloroquine for this patient, and primaquine for the prevention of the 14 days for the Vivax patients. Plasmodium falciparum. For the northeastern areas, Meghalaya, Manipur, Assam, these regions you are going to give the artesunate, artemether, lumefantrine and primaquine for 1 day. And for the remaining state like Tamil Nadu, Andhra Pradesh, Mumbai or Bangalore, all these patients you are going to give the artesunate, sulfadoxine, pyrimethamine and the primaquine is given for this patient. Next, coming to the pregnancy. In the pregnancy, the falciparum patients, quinine is given, and for the Vivax patients, you are going to give the chloroquine is only going to give it. Next, for the prophylaxis, this is for the prophylaxis. For the short-term trip, doxycycline. For the long-term trip, it is a mefloquine. And 100 mg per daily doxycycline, 250 mg per weekly, that is a mefloquine. And post-travel also you have to take up to 4 weeks after. And pre-travel 1 to 2 days before doxycycline, 2 to 3 weeks before mefloquine is taken for the treatment. Next, malaria indicators. Annual parasite incidence is important for the malaria impact, and ABR, annual blood examination rate, is the operational indicator and prevalence of the fever, and slide positivity rate is for the outbreak indicator, and infant parasite is the indication for the recent transmission of the malaria. And coming back to the malaria vectors, we have here, you can see the malaria vectors such as Anopheles. This is the malaria causing Anopheles, right? It is present in the clean water. It is present in the clean water, and the larvae is look like a boat shape, right? They travel up to 3 kilometers. Mostly they will bite in the nights, right? They will be mostly bite in the nights, and it is present in this position. And the body is having the stripes. The body will be, sorry, the wings will be having the stripes. Here you can see this is a wing, right? Stripes that is seen in the Anopheles mosquito. Next, coming to the Aedes mosquito. Aedes mosquito having the stripes on the body. So that's why it is known also tiger mosquito. It is going to cause the dengue. Most commonly it is going to cause the dengue, right? And also West Nile fever, yellow fever. All this will be caused by the Aedes mosquito. And where it is present? It is present in the dirty water. It is present in the dirty water or the stagnant water, and larvae is going to be in the cigar shape, and it can travel up to 200 meters, and night time it will be bite. Okay, night bites, and also sometimes day bites. Next, last one is a culex. It is present like a flat brown color. This will be looking only one which is going to look like a brown color, and it can cause the Japanese encephalitis and Ocharidia bancrofti, filariasis, and it is present in the dirty waters, right? And they having the larvae which is looks like a cluster formations. Okay, and it can travel up to 10 kilometers, and mostly it will be active in the evenings. Next, moving on to the identification. Here you can see this is a redweed bug. This is the redweed bug. It can cause the trypanosoma, and this is the sandfly. This is going to cause the leishmania, and this is a scrub typhus. This is a soft tick, and this is the hard tick. This is the hard tick, and it is going to cause the Karnataka fever disease. And next, this is the lice. Okay, pityriasis pubis, pityriasis bovis, and the pityriasis corporis. This is caused, and this is a flea causing the plague condition, right? Plague condition. Next, how can we treat this prevention? Please watch the PSM video where we attach the prevention of this vectors. Okay. Next, trauma primary survey, which includes the airway, breathing, circulation, disability, and the exposure around the patient. Secondary survey is a complete examination, ample allergies, medications, past medical history, and the last meal has to be checked for the patient. Okay, that is how we are going to criteriaize. Next, you have to look after category. Is it the patient red category? This is the emergency condition. Immediately that you have to treat this patient. Okay, immediate intervention has to be done for this patient. Okay, next, followed by the yellow color. This is done for the delayed patient. Treatment can be given later. Treatment can be given later. Next, green color. This is very minimal. A patient is having the minimal. OPD is done for this patient. And next we have the black color patient. These patients are dead patient. No intervention is obviously needed, not needed. Next, SOFA score. Q SOFA score is done for the shock patients. What is the criteria that you are going to see? First, BP less than 90 and patient is having loss of consciousness or altered mental status, and RR is less than, the patient is having the heart respiratory rate which is more than 22 per minute. This is the shock score. Quick SOFA score will be seen. And next, shock index, heart rate by the systolic BP, or the revised shock index, heart rate by the mean arterial index you are going to see. Okay, that is how we are going to see. Next, coming to here, this is the gauges that you are going to check. How can you remember this? As we discussed, so orange color, which is the lava, then followed by the gray, this is the soil, and green, here you can see this is the green color, 18 gauge, plants, then pink color, flowers and blossom, the sky, and next sun, which will be the yellow color, and the violet, right? This is how you can remember, and the numbers has been asked. So in the patients with the increased liver trauma, so the patients with the liver trauma and uncontrolled bleeding, what we can do, this is the maneuver they perform. This is known as a Pringle maneuver. In the Pringle maneuver, you are going to block the artery and the vein. Both will be blocked in the Pringle's maneuver. In this Pringle's maneuver, you are going to block. Next, coming to the blood. In the massive transfusion, what is meant by the massive transfusion? More than 4 units in 24 hours or more than 10 units in 2 days. So this is the massive transfusion of the patient. It can cause the metabolic alkalosis and increased potassium level, decreased calcium level, okay, and it is going to cause the severe complications such as tacho or severe trally and even febrile hemolysis, right? This can be detrimental for the patient, right? These are the important points. Next, BLS. This is the last topic, and the next remaining topics we will be discussing tomorrow. So BLS is common one which is frequently asked in the examination. How we are going to perform the BLS? First, verify the patient status. Is the patient pulse is present and the breathing is present, then call the emergency room and send the patient. But the patient breathing is not present but the pulse is felt, then give the breath, one breath for every 6 seconds, so 10 breaths per minute that you have to give, and check the pulse every 2 minutes and send the patient to the emergency department if the breathing is abnormal. But the patient breathing is not absent, pulse is also not absent, then you have to start the CPR. How much is the CPR? 30 is to 2 breaths that you have to give for the patient. And once the defibrillator is arrived, check either it is a shockable rhythm or the non-shockable. If it is a shockable rhythm, give one shock and resume the CPR for the 2 minutes. And if it's a not shockable, please continue the CPR and check every 2 minutes of the AED that has to be checked for this patient. How much is the depth that you have to going to see? At least 2 feet that you have to see for the depth of the patient, and until the reperfusion has to be seen in this patient, right? This is how the BL is done, and all these topics has been asked previously and important topics guys. Please do revise them And do watch the part 1, part 3 also for the upcoming one and all the rapid revision videos. And do practice the Q-bank. Those who are new to this channel, please do subscribe and share with your friends. Until then, see you in the next video of the part 3. Thank you guys.